speak to you today. I do it in part, perhaps because I have some experience looking at the damn squiggles, but in part is out of the great desire on my part, or express to you the wish that I had these resources in my career, the access to this kind of intelligence and, as I said, computer resources. And I want to both begin and end today with an expression that what you do is important. What obstetricians and caregivers do is important, and I submit what you do is important. And I would like to share with you some notions not derived from engineering or mathematical principles, but from a great deal of experience looking at these tracings, especially looking at the tracings of babies who would subsequently become brain injured. I want to begin the talk with Usain Bolt, and the reason I share with you, does everybody know who Usain Bolt is? He runs quickly. He runs faster than anyone else. Unfortunately, science cannot explain why he does this. He has been called a freak of nature. There's a very interesting article on the physics of what Usain Bolt does in the European Journal of Physics, and they concluded he cannot do what he does. He's too big, he weighs too much, he just seems to go faster. For my point, I want you to remember one thing, because I shall bring it back. It's not what he does in the race, how fast he is. Has anybody ever seen Usain Bolt after the race? He is running around, he has a flag over his head, he is glad-handing everybody who is in his way, and he has not paid very much of a penalty. He has not used up very much reserve in that exercise. Imagine now that you ask Usain Bolt to run it again. And when he's done with that, run it again. And when he's done with that, run it again. And I think you can expect some deterioration over time, as game and resourceful as he is. And I want to use that introduction to welcome you to the notion of the fetus during labor. What do we want out of our care during labor, and how do we get it? We want to safeguard the mother, we want to safeguard the fetus, and we also want to, in the United States at least, safeguard the healthcare provider. We want to avoid creating the need for emergency intervention. Of all the quality measures of obstetrical care, most of them, outcome, long-term outcome, brain injury, low APGAR scores, all of those things require long-term follow-up. There is, I believe, an important short-term metric. The use of emergency cesarean section or emergency vacuum delivery in a trial of labor. We're not talking about someone who comes in with an abnormal pattern. We're not talking about someone who comes in with a prolapse of the umbilical cord. We are talking about a normal patient, and I would like to submit the creation of an emergency under those circumstances is usually preventable and most reasonably a short-term metric of the quality of care. We need to minimize the need for intensive care. We need to minimize the impact and the potentially large impact on subsequent brain development. The way we're going to do it is some of the notions that Diogo and others have emphasized, is this attentive, pertinent care that is timely and that is based on physiologic principles. And the question is, how do we get all of these desiderata? And I believe we ask three questions and adopt a philosophy. Is there anything I have to do for the mother? Is there anything I have to do for the fetus? And what is the feasibility of safe vaginal delivery? I submit that every piece of information that is generated during labor must go into one or more of those three buckets. And then you have to adopt the philosophy. And the philosophy is you are not here to see how close you can get to disaster before rescuing the baby. You are here to avoid the need to rescue. For those of you who want some anchoring in statistics, you need to know the dimension of the problem. What is the relationship between long-term outcome and asphyxia at the time of birth? Well, what I want you to do is pick a number, and I'm going to provide you with a study that justifies that opinion. So if you want 3%, I'll give you one of those. You want 50, I'm happy to do that. The fact is, this is chaos. It disturbs me a lot that you notice I didn't put pH on what do we want to know or one of the requirements. pH is a risk factor. It is not a surrogate for injury. The vast majority of babies with low pH do not go to the nursery, do not have neurologic complications, are not sick in any way, and I don't understand really why you want to do this, use this so widely as a parameter, unless, of course, it's the only thing you can measure. You can't measure more important things like cerebral blood flow, behavior, and things like that with a lab test, but you can measure pH, and there's this putative relationship, which is disputed about the role of asphyxia, acidosis in the genesis of heart rate, of neurologic injury. The fact is that pH is not a good predictor, that the risk of adverse outcome with very low pHs is exceedingly low, significantly less than 10%. It is disturbing to me that the focus on hypoxia does not focus on the two hypoxemic or asphyxial stresses that the baby is capable of subjected to. And the analogy would be to give you a choice. I can either put you in a room with decreased oxygen availability, or I can clamp your carotid. You have the choice. Both ultimately will result in brain damage, but they result in brain damage by two very different, at least initially, routes to that endpoint. Ultimately, whether the clamping of the cord or the decrease in oxygen, ultimately the brain becomes ischemic. That is ultimately whether you have interfered with blood flow or interfere with the ability of the heart to pump, you are going to have diminished blood flow. That is called ischemia, and that is the final mechanism of neurologic injury related essentially to the events of labor, with a small contribution perhaps from infection. Most of you either know about or have heard about the use of cooling and the benefits of therapeutic hypothermia. The model from Antonia's adoptive parents is the group from New Zealand, Alistair Gunn, prepared a sheep model, and what they did to test the benefits of cooling is they clamped the carotid artery. That is the experimental method for justifying therapeutic hypothermia in cases of severe perinatal asphyxia, adopted worldwide. It is based on the sheep with a surgical interruption of cord blood. It has nothing to do with low pH, deprivation of oxygen. The method was the elimination of blood flow. One of the problems we have is that hypothermia was originally restricted to very severe babies who were very severely affected. We've now come to understand even that mild encephalopathy is associated with a significant risk of MRI abnormalities of the brain. And you can see whether it's, you could have seen on the last slide the fact that, I thought it was something I said. Thank you, that's it. Irrespective of the parameter, whether it's behavioral, whether it's MRI, the fact is that even mild encephalopathy without severe depression at birth, without severe need for resuscitation, without severe abnormalities of adaptation, that these babies also have not only abnormalities on the MRI, but abnormalities on IQ, developmental quotient, and things like that. This is the point that I was making before, that Levine made before me, is that we have taken advantage of the fact that we can measure pH and made it far more important, I believe, than it deserves. The problem about using pH, the problem about using the degree of encephalopathy as a measure of what you have done or the quality of care is it places considerable restrictions and blinders on how we look at obstetrical care, because it narrows the perspective of outcomes related to obstetrical care. It almost certainly underestimates the true incidence of harm, and it undervalues the benefit of skilled human intervention. There is no species known to man, including man, that does not benefit from skilled human intervention. This is an editorial in the Journal of the American Medical Association. The author is complaining about fetal monitoring because he just was successfully sued for $50 million. $50 million. And he's complaining, not complaining, I suspect, about the 50 million, but he is also complaining about fetal monitoring doesn't work. Why are you testifying in court that I'm responsible for this bad outcome based on the 50 million? First thing I have to tell you about $50 million is, as you now know, I testify sometimes. What can I say that's worth 50 million? And if there is something that I could say that's worth 50 million, in all fairness, what am I doing here? Okay. I can't say anything worth $50 million. When you hear 50, 40, 120, the largest award I've ever been associated with is $140 million. Please know that the defense is lying. There is no way to justify this kind of award. And you can't justify, you will never see one of these runaway verdicts in a doctor who gets up in a courtroom and says, I wish I had the day to do over again. Never happened. Never happened. That somebody who said, I see the error, I see the mistake, and I should have done better, and I will do better next time. No 50 million. He may even get off, but no 50 million. And then we have enough ammunition from what is written. This is 18 of our most prominent obstetrical citizens talking about how we have to deal with this so-called Category 2 tracing, which Diogo has already emphasized its problems. And among the conclusions was, as a medical community, we seem to know less than we thought we did nearly 30 years ago. And this is the schizophrenic algorithm. And they went on and tested their algorithm, and they figured out that it really doesn't work. It has significant limits, and that it can't produce anything close to sensitivities for acidemia for over 50%. Not included in the majority of the classifications is the fact of fetal behavior. An attempt to use this extraordinary device to make a neurologic behavioral diagnosis. It doesn't make a distinction between hypoxia and ischemia, which is relatively simple to do. It does not consider the mechanical effects, including, except in some, this notion of excessive uterine activity. It does not use the fetus as its own control, considering the differences in what's tachycardia and what's not. A baby who goes from 150 to 160 is probably one physiology, and a baby who goes from 110 to 150 is probably a very different physiology. So there is no sense of using the baby of its own control, and they do not understand that it's not published that CTG can be a marker, a biomarker of fetal neurologic injury. Part of the confusion is nomenclature. This is a study from Sweden by Johnson. She took 80 babies with neonatal encephalopathy, divided them appropriately according to the heart rate pattern on admission, and then she asked low pH, high pH, normal pH, low pH. The babies who were neurologically compromised with low pH, she called HIE, hypoxic ischemic encephalopathy. The babies with normal on admission, abnormal encephalopathy as a newborn, but whose pH was elevated, she gave the name no HIE. That is the designation of babies with neurologic symptoms and signs whose pH of the cord blood was above 7. The fact is the adverse outcomes are the same, the neurologic findings are the same, the MRI findings are the same. You can read as well as I can speak. This is what you would really like to do, and I submit the most important question is the last one. How did you like that one? How did you like the next one? Bolt, how did you do in the next race, and the next race, and the next race, and the next race? This, it seems to me, is the most important question we can ask, because you are asking the baby in relationship to a stress, not when it's sleeping, not when it's awake, but when it's being subjected to an impairment of its availability of oxygen. You are asking that fetus, how did you like that one? How did you like the pressure on your head? How did you like the pushing? How did you like all of these factors? It's like in an adult intensive care unit, somebody comes in and kicks the bed every 2 or 3 minutes. How did you like that one? It's like a bad reporter. It goes out and makes the news. Fetal monitoring is not content to sit back and watch something natural event. Natural event is the repetitive stress of uterine contractions, of pushing, of abnormalities, of perfusion from the mother. And what you want is, how did you like that one? I put this up not because not small, only to suggest the answer to the question, how did that, you like that one, is not in the deceleration itself, but in the recovery of the deceleration. It is not important how high Bolt's rate went, how low or high his blood pressure went, how high or low his pH went. At the end of that race, he had the flag up, was running around, could talk to you, and do all of these things, saying, whatever reserve I had to use up, I didn't use very much of it at all on that first race. And so the answer to, did you recover from, how did you like this one, is you return promptly to the previously normal baseline rate and variability, which was part of the pattern that Diogo just mentioned about variable deceleration. And anything else is not a normal return. I show you here behavior. Irrespective of your experience in looking at tracings, you can see at the top 3 different patterns of variability, accelerations, and rate. That's quiet sleep, REM sleep, and active sleep. Always sleep because we don't know whether the eyes are open. And notice there is no impact whatsoever of the uterine contractions, number 2. So I believe you are entitled to 2 things. You are entitled to the notion of normal neurological behavior as well as we can test it, because that sequence is going to repeat. It's a very high order of integration to be able to do this on an ongoing basis. And 2, there is no hypoxemic or ischemic threat to this baby. There is no baby who doesn't respond to significant hypoxia or ischemia. Here's a baby. Here's a baby. I'm sorry for the 3 centimeters for those of you who are 1. If you're having problem, you now understand the problems I have at 1 centimeter. This is at 3 centimeters. And the question is, when do you want to intervene? Everybody will agree that a heart rate of 60 and no variability is probably a very good time to intervene. What I'm obviously going to try to tell you, if you are bent on prevention and not rescue, that you want to intervene here because there are simply too many contractions. It's not safe. You're driving too quickly, and when you superimpose pushing, you see the changes which you should respond to, and you see that the changes get worse and worse, and finally the baby has a bradycardia, where 100% of all of the observers, medical or not, will agree the baby needs help. And what I'm trying to tell you is the role of obstetrics, and where I believe you have to go, is prevention and keep the excessive contractions. And when the baby starts decelerating with the pushing, which is what's causing the decelerations, you need to stop half the pushes, 2/3 of the pushes, 3/4 of the pushes, or if you have to, until it recovers, all of the pushes. Should I do it? This is the tracing Rick showed you yesterday. Rick, where are you? People said they wouldn't intervene. My notion is that I would, and I would on the basis of the fact that the recoveries from the deceleration, especially with pushing, clearly don't return to the previously normal baseline, clearly required, I believe, therapy. And what Rick did not mention is the baby's final bradycardia. Now you have a choice to make. Is Dr. Schifrin guessing, or is the information in that tracing, are there really too many contractions close together? And while they nicely interrupt some of the pushing. They also have some of the pushing come close together. I'm going to try to use the tracing to make the diagnosis of fetal neurologic injury definable by MRI. Am I supposed to be in the camera? Oh, I thought I was helping. Oh, well. See, my intentions, I assure you, were honorable. The execution was wanting. I want to remind you that periasphyxia is not the same as injury, and injury doesn't mean that you were asphyxiated. Let's stand up. Dr. Ikeda, one of the most important articles, I believe, giving insight into fetal heart rate patterns. What that gentleman did is he took a clamp and he put it on the umbilical cord of a fetal sheep and forgot to take it off. Is that right? Forgot. He was distracted. He had some other things to do. And when he came back, he said, "Oh my God, what's happened?" He then sheepishly, did that work? He sheepishly removed the clamp and said, "Let me see what happened to the brain." And you know what? The brain was injured. That had nothing to do with how low the heart rate was, how low the pH was. It had to do with how well the brain was perfused during that interval, and that the only things that correlated with injury beside the duration of diminished perfusion was what the heart rate pattern was after the event. Is that clear what was shown? That while you have the clamp on with the heart rate doing whatever it's doing is not the time to diagnose injury. You have to wait till you've removed the clamp, till the baby has been given a chance to recover, and that's what happens. The basis of what I'm about to show you is an experiment done many years ago, repeated several times, with the administration of atropine to a human fetus in labor, where you see all of these decelerations with each and every contraction, and an event happens. And that event is the administration of atropine directly into the buttock of the fetus. Look what happens. The heart rate rises, the variability disappears, and the decelerations disappear. All of this reflex activity, the variability, the decelerations, the rate, the vagal suppression of the rate, have just disappeared when you block the vagus nerve. If you don't give atropine, I submit that this pattern reflects neurologic injury to the factors, to the centers in the brain that control the vagus nerve. Here is a perfectly normal tracing. It's about 7 or 8 minutes, the first 8 minutes, and the baby has a severe variable deceleration, and up until this point, it is identical to the tracing that Diogo showed you in the last lecture. Watch the recovery of the tracing. You sit there and the expectation is it's going to come back to the pattern that prevailed before. But watch this baby. This baby, despite the fact that the decelerations disappear, that it returns to the previously normal rate, has nothing like a normal rate. The baby has been injured by this 3-minute window of ischemia. I think there's no hypoxia, there's no abnormality before this event. The baby has a severe deceleration, has this overshoot following the severity of the deceleration, and the expectation is it's going to recover, and it doesn't. And I believe you are now entitled to the notion of neurologic injury. And that is essentially, I believe, what they saw in the lab experiments. And we call that the conversion pattern. And it has nothing to do with, it has to do with the rapidity of how it happens. Injury, at least on a fetal monitor, tends to be a threshold phenomenon. There can be lots and lots and lots of variable decelerations, and all of a sudden, you're going to see the sudden rise in rate, diminution in the number of decelerations, and you are reasonably, I believe, entitled to the notion of injury. We did this study in 190 or almost 200 babies in association with vacuum, and we're able to show on the basis of tracings that the injury occurred before the vacuum was placed. The risk factors for the conversion factor are identical to the risk factors for hypoxic ischemic encephalopathy and the risk factors for stroke. It's one big porridge. The risk factors are prima parity, prolonged labor, abnormalities of the fetal CTG, large size, large baby head. They are risk factors for that heart rate pattern, for stroke, and for hypoxic ischemic encephalopathy, if you make the distinction. I just show you very quickly because we're doing some research on immediate. This is the fetal heart rate pattern. This is the neonatal heart rate pattern. That's 1 minute in between them. When a baby is delivered, it has this low vagus, this almost no vagal tone for about 8 to 10 minutes. And now you can watch, if you watch over time, the baby recovers over 8-10 minutes. The time to recovery is a function of the pH, the stress of labor, neurologic injury, medication, and things like that. But it's a wonderful marker of the ability of the baby to recover from, as I like to call it, a re-entry. Why is labor so long in a human? I'm sorry to tell you, but your head is not, you didn't do right. Not for your mother's pelvis anyway. The fact is we are also the only species that requires a midwife, what I call obligate midwifery. Most of these other species with shorter labors manage to deliver their own. We cannot. And in this act, in this obligate midwifery, there is a great option to do good. But one of the options is understanding the relationship, the pressure relationships between the fetal head, the amniotic cavity, and the pressure inside the fetal head. So that it's one thing before membranes are ruptured, it's another thing when the baby's head is in the pelvis. The pressure in the head is always greater than the pressure in the amniotic cavity. It's always greater. It has to be for the head to protect itself. And you have to, in order to perfuse the brain during times of increased pressure, you have to raise your pressure. And so what you are looking at in heart rate pattern is not only the ability to deal with hypoxia, but it is also the ability and the need to maintain perfusion during these times of increased stress. This is just showing you that the pressure is always higher, number one, and number two, so-called late decelerations. These are essentially often considered benign and not associated with abnormal pH, certainly represent impairment of cerebral blood flow, which has been nicely shown with ultrasound examination of flow so that when you have early decelerations, you have altered flow in the carotid and cerebral vessels. These are MRIs in the second stage of labor, showing universally, it's not a large study, but universally, all babies have molding, overlapping of bones. They have, by the second stage of labor, decreased cerebrospinal fluid. There is no denying the impact of mechanical factors that impact on the baby's head. Now, the baby has a number of compensatory resources to deal with this pressure, and sometimes called the dive reflex. The point about the reflex is you will never have it as functioning, as alertly as functioning as an adult as it is as a fetus. The reflexes dissipate over time. You don't lose them completely, but the fact is, if you make a deal with the fetus and say, only have a deceleration when you're in trouble, the term fetus will wiggle its nose at you and see, watch what I can do. And watch what I can do is important because it has to deal not only with diminution in oxygen, but these extraordinary pressures that are visited on the baby. And as the length of the second stage increases, so do all of these adverse outcomes. And there is this repetitive need. It's a boxing match, it's a swimming match, it is an endurance match, and you need to, in fact, parse that into the understanding of what is going on. I leave you with a horse. I understand that you cannot see the whole horse, but I do hope that you see enough of the horse to understand in which direction it is going. I leave you with two quotes. Thomas Pynchon, if they can get you asking the wrong questions, they don't have to worry about the answer. You can apply that to whatever parameter you wish. And Agatha Christie, who said, how much do we know at any time? Much more, or so I believe, than we know we know. Thank you very much.
Thank you very much, Barry. Questions, thoughts, comments?
Struck speechless.
I've got plenty, but I'm going to be nice.
Well, you can be nice.
Thinking.
Or don't be nice.
Oh, I've got quite a few.
Don't be nice.
Can you go back to the slide with the new MRIs? Can you tell us a little bit more about that? That's brand new. Has anybody seen that before?
Which, the MRI of the mild?
No, the 2019 Army.
This is brand new.
Yeah, exactly. Can you tell us what?
What I'm showing you here is these are, I wish Ami were here, but these are pictures of the distortion of the plates of the fetal head, okay? And in other views, which I didn't have, which I don't have with me, you can also see the distortion of the fetal head. Several things. They did 9 patients. They took MRIs at the beginning of labor, before labor, and MRIs after full dilatation. Okay? The MRIs before, the first MRI shows a normal relationship of all the bones of the skull. The second MRI shows dramatic several changes. One, it shows the displacement of the bones of the head universally. All of the 9 had it, and that becomes important in a minute. The next thing they found was there was a depletion of cerebral spinal fluid from the lateral ventricles of the brain. So the brain is clearly being compressed, and this is present before pushing, before delivery. one of the most interesting findings was that at delivery, many of the babies had no obvious molding. That is, what you are seeing was a dynamic process during labor, the dynamic process during labor to make the adjustments to allow the fetal head to fit through the pelvis, in this somewhat difficult course it has to navigate. So those are the data.
And
There's more data there about bleeding.
Ami et al. Is that a published paper? There is no journal.
Yeah, sure.
Is that what is the journal? Do you know?
I'll give you a copy.
So is this the London? Where is this MRI coming
Paris.
from? Paris.
Harry, this gives the impression that I'm not sure that's the message. I'm not sure it's not the message.
What?
That you should be delivering them all by cesarean.
No, that's the whole point.
Just to make that-
Thank you. The question was, if this is the case, why not deliver all babies by cesarean section? The answer is, I believe these are normal, relatively normal physiology, which you are here to safeguard. To the extent that you are impressed by these changes, to the extent that you are impressed by the notion that to perfuse the brain during a pushing, a contraction where the mother is pushing, okay, is an extraordinary effort on the part of the fetus. He's got enormous resources to deal with this. He's got Cushing response, he's got autoregulation, he can cool his brain, he can reduce the energy requirements of the brain, he can shut down electrical activity as a normal response. I only pray that you will watch how he does it.
You hopefully will. It will happen.
What?
It will happen. I guess.
Watch how he responds and allow him the time between one race and the next.
Perry, just a very quick question regarding this paper. Because nowadays in the ultrasound we actually do many Dopplers, and sometimes we actually don't know why we do them.
Yeah.
Apparently, universally, people are doing Dopplers in third trimester scan. Were these findings related with interest with cerebral hemodynamics, or not at all?
Which
these findings?
the Doppler or these? No, there's no. We're doing. There's no flow studies with these. The flow studies with the early decelerations was done in Russia by Ueno, and they clearly showed that as you go from between contractions and pushing, the resistance goes up and the frequency of decelerations goes down. The decelerations increase. That's clearly a rather linear relationship between the flow and the appearance of decelerations. Early decelerations are not benign. They're not asphyxial in that sense, but they are not benign.
Okay, I think everyone. I've got more, but I think everyone's going to. So we've got a busy clinical afternoon, so go get lunch. Thank you. Thank you, brother. Because I can go on all day.